Welcome back to the deep dive. Today, we're jumping into a really critical topic,
Hmm,
one that's complex, widespread, and honestly often incredibly urgent. We're talking about the vasculitides.
that's right. It's a huge field. But at its heart, the concept is pretty simple. Vasculitis just means inflammation, and necrosis, or death, of blood vessel walls.
And this isn't just, a small local issue. This is about the fundamental plumbing of the body failing.
Exactly. That great analogy from the source material.
Yeah.
The one about the city water system.
Exactly. Think of your entire circulatory system as a city's water network.
Well, okay.
If the large pipes, the main highways like the aorta, if they break or clog up, entire regions lose flow.
So clinically, that's your limb claudication.
So that's your limb claudication, your absent pulses, exactly. Now, if the medium pipes, the ones feeding the organs, if they start to balloon out,
Aneurysms.
that's your risk for GI ischemia, heart attacks, major kidney problems.
Got it. And the last one?
And then if the small pipes, the tiny capillaries, if they get clogged, you see all that micro damage, purpura on the skin, blood in the urine.
Or that really devastating alveolar hemorrhage in the lungs.
Precisely.
That roadmap is perfect.
Yeah.
So let's start with those main highways.
Stick with. Just think of vessels as pipes. With vasculitis, those pipes can narrow, right? That's your ischemia,
Or they can leak.
which gives you things like purpura on the skin.
Right. They can also get completely clogged, causing an infarct.
Or they can just burst, the aneurysm scenario.
And because the body has so many different kinds of pipes, I mean, from the massive aorta all the way down to tiny capillaries, the best way to classify these diseases is by the size of the pipe the immune system decides to attack. Large, medium, or small.
Okay, so let's start at the top. The major infrastructure. Large vessel vasculitides. And the classic case here is giant cell arteritis, or GCA.
Right. And for GCA, the demographics are a huge clue. It's almost always women and typically over the age of 50. You can almost picture the classic patient.
And the symptoms are so specific, it's not just a general headache. The sources all point to a new onset, one-sided temporal headache.
Yes, and scalp tenderness. They'll say it hurts to brush their hair or even put on glasses. But the most specific symptom, the real buzzword, is jaw claudication.
Pain while chewing.
Intense pain. It's the muscles of mastication screaming for oxygen because their blood supply is being choked off.
And this isn't just a local problem in the head, it's systemic. You get fevers, malaise, and these just off-the-charts inflammatory markers, right? ESR and CRP through the roof.
Absolutely, and that's driven by an interleukin, IL-6. It also explains the strong association with polymyalgia rheumatica, PMR. About half of patients with GCA also have that profound stiffness in their shoulders and hips.
So why is that? Why the connection?
It's likely the same underlying process. GCA is a T-cell mediated disease. It causes what we call granulomatous inflammation. You get these unique multinucleated giant cells.
The giant cells from the name.
Exactly. And their target is a specific layer in the artery wall, the internal elastic lamina. They are, and this is a great visual, literally chewing up the elastic lining of the pipe.
So the demolition crew is inside the pipe, ripping out its reinforcement.
And that's what makes this a true medical emergency,
Mm.
because of where those pipes go.
The eye. This is the pivot point. The risk of irreversible blindness.
Yes. The inflammation and the scarring it causes, it's a process called intimal hyperplasia. It can severely narrow the ophthalmic artery,
Which feeds the optic nerve.
and you get an anterior ischemic optic neuropathy, AION, sudden, painless, and permanent vision loss in one eye.
So what's the protocol? I mean, this is a life-changing event.
The protocol is simple and absolute. If you suspect GCA, especially with any visual symptoms, you start high-dose steroids immediately. VB methylprednisolone.
Immediately. So you don't wait for the diagnostic confirmation.
You can't.
You skip the biopsy.
You start the steroids first. The biopsy can wait. Vision cannot. That's the rule. The steroids can save the other eye, which is often affected next. And the good news is the inflammation is so profound that the biopsy will still be positive for a week, maybe even two,
Right.
after you start treatment.
Biopsy can wait. Vision cannot. Got it. Okay, let's stay with large vessels, but switch gears. Takayasu arteritis. Pathologically, it sounds almost identical. T cells, granulomas.
It is remarkably similar, same mechanism, but the patient is the complete opposite.
Right. Instead of an elderly woman, we're now talking about a young Asian woman, usually under 40.
A huge demographic shift.
Yeah.
And the location of the attack moves too,
So the T cells have moved from the arteries in the head.
down to the main highways leaving the heart, the aortic arch and its major branches. the subclavian, the carotids,
And that inflammation causes the same narrowing, the same stenosis.
which leads to its classic nickname, the pulseless disease.
Okay, that's what I want to ask about. Pulseless disease. If you're blocking the aorta, shouldn't you see, I don't know, heart failure or shock first? Why is a missing pulse the main sign?
That's a great question. It's because the inflammation is most common in the branches coming off the arch, like the subclavian arteries that feed the arms. So before the heart fails, the arms are starved of blood. You get weak or totally absent pulses in the upper extremities. Patients might complain of arm claudication pain with use.
And you'd see a big difference in blood pressure between the two arms.
A huge difference, often more than 10 millimillisGs. That's a massive clinical clue that there's a blockage upstream right at the source.
Okay, so GCA and Takayasu are two sides of the same coin. A T-cell demolition crew heading large elastic arteries. GCA, elderly head, Takayasu, young aortic arch.
That's the perfect summary.
All right, let's move down a size. Medium vessel vasculitides. These are the muscular arteries. And we have to start with polyarteritis nodosa, PAN.
And with PAN, the whole mechanism changes. We're leaving the world of T cells and entering the world of immune complexes. Type 3 hypersensitivity.
So if GCA was a demolition crew, PAN is more like sludge, immune debris getting stuck in the pipes.
That's a great way to put it. This sludge, these immune complexes, often form because of chronic infection. The classic association here is hepatitis B. About a third of PAN cases are linked to it.
And what does that sludge do to the vessel wall? The pathology sounds intense. Transmural necrotizing vasculitis.
It's an aggressive, destructive process that goes through the whole vessel wall. It causes fibrinoid necrosis, and because these deposits happen at different times, you get this patchwork of damage. Some spots are acutely inflamed, others are healing and scarred.
Which gives you that classic buzzword on an angiogram, the string of beads.
Exactly. The string of beads is just a visual of multiple small aneurysms, the beads alternating with narrowed segments or strictures, the string.
And since we're in medium visceral arteries, what organs are getting hit?
You just follow the pipes. The kidneys are a huge target. This causes severe hypertension, renal infarcts. But importantly, not glomerulonephritis. It hits the artery, not the filter.
Okay, what else?
The GI tract. You get mesenteric ischemia, what's called intestinal angina, terrible abdominal pain after eating, and the nerves. A classic finding is mononeuritis multiplex. Foot drop's a common example.
But the single most important differentiating feature for PAN, the thing that sets it apart, is what it doesn't do.
Absolutely, 100%. PAN spares the lungs.
No lung involvement.
Zero. It's a disease of the high-pressure systemic circulation. It leaves the low-pressure pulmonary circulation alone. So if you see a patient with kidney, gut, and nerve problems, but their chest x-ray is clean, you have to be thinking PAN.
Got it. Now for our other key medium vessel disease, a total shifting gears to pediatrics, Kawasaki disease.
Yes, KD. This is a vasculitis of early childhood, primarily kids under 5, with a higher incidence in Asian children.
And the diagnosis is all clinical, based on a mnemonic, right?
It is. It's crash and burn.
Yeah.
Burn is the mandatory part. A high fever for at least 5 days. Then you need 4 out of the 5 crash criteria.
Let's run through them. C is
Conjunctivitis, bilateral, no plus, crash. It could look like anything, so we say polymorphous. Adenopathy, swollen lymph nodes in the neck,
S.
strawberry tongue, or just red, cracked lips, changes in the mouth. Hands and feet, they get red and swollen, and later the skin on the fingertips and toes peels off.
It sounds just awful for a little kid, but the real danger isn't the rash or the fever, it's the heart.
That's the critical point. KD has a terrifying predilection for the coronary arteries.
The medium-sized vessels of the heart.
Exactly. Up to a quarter of untreated kids will develop coronary artery aneurysms,
Aneurysms in the heart of a toddler.
which can then clot off and cause a heart attack.
Yeah.
A myocardial infarction in a 2-year-old. It's a devastating complication.
So treatment has to be fast, and it has to be effective, and it's very unique.
It's one of the only times we do this in pediatrics. We give high-dose aspirin
To a child.
to a child.
Yeah.
First at high doses for the anti-inflammatory effect, then at a low dose to prevent clotting. And you combine that with IVG intravenous immunoglobulin. If you give that combination within 10 days of the fever starting, you dramatically reduce the risk of those coronary aneurysms. With Berger disease or thromboangiitis obliterans, if we're talking about unique triggers, this one has to be the most straightforward.
It is, because Berger kind of stands alone. It's the environmental one. It's a segmental inflammatory disease of the small and medium arteries. But here's the crucial distinction.
What's that?
It also involves the veins and nerves. That's not typical. It affects all three structures, usually in the hands and feet.
And the patient profile is incredibly specific, correct?
Oh, extremely. We're looking almost exclusively at men under 45 who are current or very recent smokers.
The sources are so clear on this. Smoking isn't just a risk factor. It's the absolute essential trigger for the disease.
That's the mechanism. Tobacco exposure injures the vessel lining, which leads to these highly segmental inflammatory thrombi.
Which clinically shows up as well.
Yeah. Extreme distal ischemia. You see pain at rest, especially at night, and then this awful progression to ischemic ulcers and, even gangrene of the fingers or toes.
Our sources call this the burner toes clue. But what about the veins and nerves you mentioned? How does that separate it from, say, standard peripheral artery disease?
Well, you look for signs that the inflammation has spread. You'll often see what's called superficial thrombophlebitis.
Like tender, cord-like feelings along the veins.
Exactly. And because the nerves right next to them are involved, patients also get paresthesia, that pins and needles feeling, and cold sensitivity.
And the damage is all the way at the end of the line, so to speak.
Right, very distal. The large arteries are usually spared, which means you can often still feel strong proximal pulses.
So the analogy from the source material holds up pretty well. Segmental pipe clogging in a smoker's hands and feet, and the wiring and drainage pipes next to it get damaged too.
That's a good way to put it.
So if tobacco is the trigger, the definitive treatment that stops it has to be
The only thing. Complete and total smoking cessation. Other treatments, like vasodilators, they just offer symptomatic relief. They don't stop the process. If the patient keeps smoking, the disease will progress. Amputation is a very real risk.
Okay, let's leave that environmental trigger behind and move into the world of internal immune attack, the ANCA-associated vasculitides.
Right. Now we're talking about small vessel autoimmune diseases that are what we call pulsi-immune.
Meaning they lack those big immune complex
Deposits.
precisely.
And for these three, GPA, MPA, and EGPA location is everything. They're defined by anti-neutrophil cytoplasmic antibodies, or ANCAs, and they all have a nasty habit of targeting the lungs and kidneys.
The dreaded pulmonary renal syndrome.
A true medical emergency, so we have to focus on the structural hallmarks that distinguish them.
Let's start with granulomatosis with polyangiitis, GPA, formerly Regeners. What are the two features that absolutely define it?
GPA is a necrotizing vasculitis, and it involves two things that, for example, MPA lacks. First, the presence of necrotizing granulomas, and second, prominent upper respiratory tract involvement.
So it's a classic triad.
The classic triad. Upper airway, lower airway, so the lungs and the kidneys, leading to that rapidly progressive glomerulonephritis, RPGN.
The sources highlight CA-NCA positivity as the key lab finding. But clinically, what are the high-yield physical signs of that upper airway destruction?
You're looking for destruction of cartilage and bone. So that means chronic refractory sinusitis, recurrent ear infections, and potentially a saddle nose deformity where the nasal septum is just destroyed.
Wow. And in the lungs?
The lung lesions tend to be cavitary. They form cavities, which reflects that necrotizing pathology.
Okay, now let's move to microscopic polyangiitis, MPA. It also causes that severe pulmonary renal disease and is usually PANCA positive. So how do we tell it apart from GPA?
That is the crucial distinction. MPA is a pure necrotizing capillaritis. It does not form granulomas.
No granuloma.
And critically, it spares the upper airway. You won't see the chronic sinusitis or the saddle nose. If a patient comes in with severe lung hemorrhage and kidney failure, and they're PANCA positive but have no ENT issues,
You're thinking MPA.
MPA is the leading diagnosis.
That makes the structural difference. Granulomas versus no granulomas, the core distinction. Okay, finally, let's bring in the third one. EGPA, eosinophilic granulomatosis with polyangiitis.
Historically, Church-Strauss, yes. This one has a huge allergic component.
Right, another triad.
Yes, its own distinct triad. 1, a history of long-standing, often hard-to-control asthma. 2, significant eosinophilia in the blood and tissue, often over 10%. And 3, the systemic vasculitis itself.
And it can be PANCA positive, but not always.
About 40 to 60% of the time, yes.
And the symptoms here seem to be driven by those eosinophils causing ischemia, especially to the nerves. What's the high-yield symptom here?
Mononeuritis multiplex. It's a type of peripheral neuropathy where the patient develops asymmetric weakness, like a sudden foot drop or a wrist drop. It's from nerve ischemia.
They also get those migratory lung infiltrates, right? and cardiac involvement.
Yes, the lung infiltrates are transient, not cavitary.
Hmm.
And tragically, cardiac involvement is a major contributor to mortality in EGPA.
I saw a fascinating note in the sources about EGPA flares and asthma medication. Can you explain that link? Something about high-dose steroids.
Yes. It's a clinical pearl, really. EGPA can sometimes be unmasked when a patient with severe asthma tries to taper off their high-dose systemic corticosteroids.
So the steroids were suppressing it all along.
Exactly. They were masking the underlying eosinophilic activity, and once you pull them away, the full force of the vasculitis can emerge.
Okay, time to shift gears completely. We've covered the post-immune ANCA-driven diseases. Now let's focus on the ones driven by massive immune complex deposition,
Where the immunoglobulins themselves are the problem. We can start with IgA vasculitis, or Henoch-Schönlein purpura, HSP.
which is fundamentally a pediatric disease.
The most common vasculitis in children, absolutely, usually between ages 3 and 15.
And it often pops up right after an upper respiratory infection, which suggests some kind of infectious trigger for these IgA immune complexes to form.
That's the thinking.
So what's the classic tetrad of symptoms we need to remember for it?
The 4 parts are essential. 1, palpable purpura, characteristically on the lower legs and buttocks.
Okay.
2, joint pain or arthralgia, usually in the knees and ankles. 3, gastrointestinal issues, like significant abdominal pain. And this carries a rare but serious risk of intussusception.
And number 4 has to be the kidneys.
The kidneys, renal involvement, typically blood and protein in the urine, following that IgA nephropathy pattern.
That IgA complex deposition is really the whole story there. Let's move to our last one, cryoglobulonemic vasculitis. This one has a huge non-autoimmune trigger.
It does, and that trigger is chronic hepatitis C infection. HCV underlies something like 80% of all cases.
So how does that work? What's the mechanism?
It revolves around these circulating cryoglobulins. These are immunoglobulins that precipitate or, clump together when they're exposed to cold temperatures.
So these circulating clumps are the immune complexes causing all the inflammation. What are the key clinical findings?
Well, you see palpable purpura, again, especially on the lower legs. Peripheral neuropathy is common. And a type of kidney injury called membranoproliferative glomerulonephritis, or MPGN.
But the lab signature is the most distinct clue, isn't it?
It really is.
And that would be the low complement level,
Right.
specifically C4. Why is that so critical?
It's crucial because it reveals the pathology. Remember, the ANCA diseases are pauci-immune, no big complexes, so complement levels are usually normal.
Right.
But in cryoglobulinemia, the constant formation and deposition of these huge immune complexes triggers and then consumes the complement system. That leads to a measurably low C4 level. It confirms the whole process.
And since HCV is the engine driving this, the most powerful treatment must be to target the infection.
Exactly. The definitive treatment is to eliminate the underlying cause. You use direct-acting antivirals, the DAAs, to cure the hepatitis C.
We did it. We navigated 6 distinct forms of vascular inflammation to synthesize those key differentiators for you to take away.
If you see a young male smoker with distal gangrene and it involves veins and nerves, that's Berger disease.
If you have that massive systemic triad of ENT issues, granulomas, and kidney damage, look for CANCA and think GPA.
If it's mainly pulmonary renal disease with PANCA, but without the granulomas or the upper airway stuff, that's MPA.
And if you add a history of severe asthma and massive eosinophilia, especially with that unique mononeuritis multiplex nerve damage, you are looking at EGPA.
Then for the immune complex diseases, a child with palpable purpura, joint pain, and abdominal pain after a URI.
That's IgA vasculitis, or HSP.
And finally, an adult with purpura, neuropathy, and a critically low C4 level, very often linked to hepatitis C, that points strongly to cryoglobulinemic vasculitis. Profile, vessel size, and the one key feature.
Okay, ready. Elderly patient, new headache, immediate vision risk.
GCA. Start steroids now. Don't wait.
Young Asian female, weak or absent pulses in her arms.
Takayasu. The pulseless disease.
Middle-aged man, hepatitis B, abdominal pain, but a totally clear chest x-ray.
Can. No lungs.
A child with a fever that won't quit, strawberry tongue, and you're worried about their heart?
Kawasaki. IVA and aspirin immediately.
Okay, small vessels. Let's do the ANCA patterns. Lung-kidney syndrome plus signs of chronic sinus destruction.
That's GPA, CANCA. Look for granulomas.
Same severe lung-kidney syndrome, but absolutely no ENT symptoms.
That's the key differentiator for MPA,
Yeah.
PANCA.
And if they have adult-onset asthma with just massive eosinophilia,
EGPA, the allergy-driven one.
that is the definitive checklist.
Yeah.
Okay, before we go, let's leave our listener with one final provocative thought.
Sure. So we talked about GCA and Berger disease, and they're driven by these systemic immune responses,
Oh,
right?
yeah.
But they're both known for having segmental involvement. The skip lesions in GCA, where only patches of the artery are inflamed, or the segmented clots in Berger's. It raises a really interesting question. If the whole body's immune system is primed for this, why does the damage only hit specific, localized spots on a vessel? It sort of suggests that local factors, maybe mechanical stress, maybe some local antigen, are what actually pulls the trigger for the final destruction.
So even in a systemic disease, the specific environment of the vessel wall itself might be the ultimate ignition point. A fascinating final thought. We hope you use these distinctions as anchors as you continue your own exploration.